Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article number 3. Welcome to the Pain is Not the Only Problem podcast. The essentiality of conservative care is being reevaluated. The contributors to patient symptoms are being re-explored. All options are on the table. Article 3, Pain is Not the Only Problem. Evidence. These articles intend to 1. Reevaluate the prevailing clinical practices thought to manage low back pain. 2. Submit and debate novel low back pain contributors and mechanisms. 3. Meet patient expectations and satisfaction and clinically meaningful results. 4. Recommend a conservative, non-surgical course of care to override pain instantly. And 5. Restore ADLs and patient confidence on the first visit at low cost. Much of the clinician's attention regarding a low back complaint is directed to the site of pain, then looking for diagnostic features to explain the pain, then prescribing a course of care, also called a treatment plan, then doing back office work and getting paid. All of that appears to be completely normal and usual model in the clinician's office. However, that is all wrong. It isn't a doctor-patient relationship. It is a patient-doctor relationship. Patients seek help because they have a problem and they can't solve it on their own. The patient brings the complaint to the doctor, not the other way around. The patient is in charge. The patient is the consumer. The doctor agrees to service the complaint by providing supervision and care to meet the patient's needs. Expectations on effectiveness, of course, safety, side effects, number needed to treat, and efficiency, value, time, costs, referral visits, patient engagement and education, number of return visits, course of care perceptions, and bias. Does the patient believe that your recommended course of care is just? Is it sufficient, warranted, and essential? A primary diagnosis for low back pain is likely due to abnormal movement patterns associated with the symptomatic area, but not specifically at the symptomatic area. Also known as SCAD, S-C-A-D, symptomatic compensation to associated dysfunction. The human body is primarily two things. Number 1, a task machine that acts to produce and manage mechanical work. And 2, a chemistry machine that acts to manage myriad reactions of decomposition, synthesis, combustion, etc. in order to help the task machine function. With diagnosis, the best place to start is with a functional evaluation that is mechanical and chemical. Which operations of the entire person are not working properly? In the case of a 34-year-old right-handed single tennis player with low back pain on the right side, and upon functional evaluation, seen by looking at videos on her phone, she appears to be facing the net directly instead of the classic sideways stance during her forehand swing, forcing her into too much right-sided rotation and producing learned spinal instability. You can't see this with orthopedic exams and definitely not on an MRI. Remember, everything you need to know diagnostically is in the patient presentation and history. Do you have the skill set to do this kind of evaluation? Drugs are not going to fix her swing. Blaming disc height isn't going to fix her swing either. Correcting the swing fixes her swing and begins to address her back pain, since there may be other factors involved with her swing, her stance, and other problems. And in all cases, drugs will never prevent re-exacerbation. Since we're agreeing not to focus on pain in these articles, but rather on mechanical chemical contributors to the entire patient experience that includes low back pain, let's build out another layer to offer the patient best possible outcomes by utilizing the best available current medicine. This medical evidence should focus on the parameters of the patient's values and not on the saleability of a specific type of treatment, since a reductionist approach is likely to fail at the expense of the patient. The evidence should 1. Meet at least Class B RCT standards, 2. Offer patient education, 3. Be based primarily on an at-home or remotely supervised active care, 4. Encourage patient accountability, and 5. Involve changes to lifestyle, sport, and intrapersonal contributors. The completely normal and usual model of medicine commonly does not meet diagnostic care Class B RCT standards, asks nothing from the patient, does not involve their consent, and does not offer them options such as conservative care. It does not fully explain NNT, number needed to treat, the risks or likelihood of no benefit, and what will happen if the symptoms are not corrected satisfactorily. The completely normal and usual model of medicine does not respect the waste of patient time and expense, delays in meeting patient expectations, and prescribing without asking and respecting patient values. The completely normal and usual model of medicine is a cookbook, an old cookbook with a lot of missing ingredients. The medicine of today is not a cookbook. It is a dynamically evolving interchange between researchers, artists, critical thinkers, and dreamers. I wanted to find a one-visit solution for any kind of chronic or acute non-traumatic low back pain at low cost, so I went on that journey and found my answer. Along the journey, I learned a lot about the practice of medicine that disturbed me because it wasn't directed towards patient values. Advocate for your patients by listening to their story, because pain is not the only problem. Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-cultural willingness to strengthen medicine. Thank you.